When we screen people, what we're trying to do is capture disease under the bell curve. Population statistics is about finding out what's good for society. That is, we don't want to do too much, but we want to be able to catch enough disease to help a bunch of people. So what we've come up with are screening guidelines based on studies we've done that tell us these things are good to do because by doing them, more people benefit and less people get harmed. You, of course, have to consider the number needed to treat, that is, how many times do you have to do this for someone to benefit, versus the number needed to harm, how many times you need to do this for a complication, and then compare how bad the complications are relative to the perceived benefit. You don't have to do any of that. In this lecture, let's just talk about what you do to screen, know what diseases, how to do it, and when to start. Two things, cancer and medical disease. Let's start off with cancers first. Cancer, when you start screening, how you screen, and when you stop. The most important cancer for the test is colon cancer, and you want to start screening for colon cancer at age 50 or 10 years before the first diagnosis. That is, if your father got diagnosed with colon cancer at 42, you should be screened at 32. Age 50, or 10 years before the first diagnosis in a primary relative, whichever one comes sooner. The reason why I put colon cancer at the top is because the way you screen is the most complicated, and any of these count. But if you change the number of frequency of year, you can make a right answer wrong or a wrong answer sound right. The best thing that you can do for colon cancer screening is a complete colonoscopy, and that is done every 10 years. But you can also do a flex sig every 5 years with fecal occult blood testing every 3 years. Or you could do a fecal occult blood testing every year. Now you can see how they can say these words and then change the years and really screw you up. So as you remember this, colon's 10, flex is 5 with an FOBT 3, FOBT 1. 10, 5, 3, 1, it's in descending order. All of these are fine, and I use FOBT, fecal occult blood test, to mean any way of examining the stool for microscopic blood. You're going to hear about the FIT. For you, it is essentially the same as fecal occult blood testing. It doesn't matter which one you do, they are the same. You're going to continue colon cancer screening until 75. But there's pretty good evidence you should continue past 75, but for certain people. The idea is it takes about 10 years to develop from a polyp into cancer, which is why the colonoscopy is 10 years, and you start 10 years from the first diagnosis. If you're going to live more than 10 years, you should probably have colon cancer screening continued. So definitely do colonoscopies until 75 and until 85 if they're really healthy. After that, don't put them through an unnecessary test. The next big cancer is breast. Now, the way we screen for breast cancer has changed a little bit. You may still see people prescribing the old way of doing it. For the test, that way is wrong, even though some societies still recommend it. We are going to use the new recommendation. The old recommendation was to begin at 40 and screen every year. This is no longer the case. What we do now is 50, begin at age 50, and then screen every 2 years with mammography. The idea is something like this. If you do 40Q1, you will catch more breast cancer. And that person that you found positive before age 50 may benefit. But this is about populations, and statistics is about population level and cost-conscious care. Your patient in front of you may have a cancer and you don't diagnose it. But the problem is that the number of patients that need to receive that 40Q1 actually harms more women than it helps. Women were going through lumpectomies and biopsies leading to abscess and lymphedema, such that a false positive rate was too high, causing too much morbidity. So 40Q1 does catch more cancer, but isn't worth it at a statistics level, at a population level. 50q2 balances catching women with breast cancer, but reducing the morbidity associated with false positives. You continue until age 75. The other female cancer we screen for is cervical. The right answer is to start cervical cancer screening at age 21. The age at which you began having sex is absolutely irrelevant. Again, population under the bell curve. If you have a high-risk patient, like someone who's had AIDS since they were born and are now sexually active at 11, you might want to screen her for cervical cancer. But again, what likely happens in the general population is that even those girls who are exposed early on in adolescence clear the virus and don't have an increased risk. Therefore, the age of onset doesn't matter. Age 21. The way you screen is with a PAP every 3 years. And you continue doing pap smears until either she's age 65 and has 3 consecutively normal paps, or she has her cervix cut out, total abdominal hysterectomy. Now, there is another option that you can use for older women. I want you to learn 21q3. If you take a woman who's slightly older, you can do PAP Q5 with HPV testing Q5. I don't want you to learn that because it becomes more complicated and it's actually hard to read on the board intentionally. I want you to learn 21q3, but know in the back of your head that there's this other option that if you do HPV testing, you can kind of delay them a little bit. That's more for woman comfort rather than cervical cancer screening. The last cancer we screen for, and that's right, we only have 4. The last cancer we screen for is lung cancer. And the people we screen for lung cancer are those between the ages of 55 and 80. And they have a 30-pack year history. And they quit less than 15 years ago. And that is including those who are still smoking. The way you screen for lung cancer is a low-dose CT scan. And you do that every year. You do that until they're either age 80 or the time that they quit is more than 15 years ago. Note that doing an X-ray does not help with lung cancer, so you should not do them for screening. If you're going to screen someone for cancer, low-dose CT. Now, I also want to point out some of the cancers that we do not screen for, and some of you might be looking for them. We do not screen for prostate cancer. We used to do digital rectal exams plus screening PSAs, and some cancer societies still recommend doing this, especially for those who are high risk, those who have someone in their family who had prostate cancer. You should learn, do not screen. The reason why we don't do this anymore is the lead time bias. This is the same timeline of exactly the same person. Here they are now. They are going to die at exactly the same time. Their fate is fixed. What happens when we screen someone for prostate cancer is that we find prostate cancer. And so they live all this time with prostate cancer. If we didn't screen for them, they're still going to die at the same time. We find that prostate cancer very close to their death. And so it looks like we've prolonged life. We've reduced mortality. This is the lead time. It turns out you die with prostate cancer, not from. Are there patients who will die from prostate cancer? Of course, but at a population level, it isn't worth it because you put so many men through unnecessary procedures, biopsies leading to erectile dysfunction and incontinence that it's not worth it. The right answer is discuss with your patient whether or not they should, but really what they're saying is don't screen for prostate cancer. The other thing to not screen for is ovarian cancer. We tried a lot of things. Serum markers with CA-125, imaging with transvaginal ultrasound, and it turns out what happens is you get disease in very late stage. And it doesn't matter that you screened because they're going to die anyway from their advanced disease. So don't screen ovarian cancer unless they're BRCA positive. More on that on the general surgery breast lecture. That's cancer. Colon, breast, cervical, lung. Colon is 50Q10, breast 50Q2, cervical 21Q3, lung cancer 55 to 80 who have smoked 30 pack years, quit less than 15, CTQ1. Change gears and go over to medical disease. In the medical disease, you want to know what disease we're talking about, who you screen, and how you screen. There are 3 one-time diseases that you are going to see on your test. Not maybe all 3 of them, but at least one. The first is the male disease, and that's abdominal aortic aneurysm. You are going to screen those men who are greater than 65 and who have ever smoked. It's men and over 65 and who have ever smoked. Unlike lung cancer, the pack year isn't considered. The way you screen for abdominal aortic aneurysm is with an ultrasound of the abdomen. But if the person has already had abdominal imaging, CT scan of the abdomen, for example, for another reason, that counts. One-time screen after 65, look for the aneurysm. Its counterpart in women is osteoporosis. You're going to screen women who are over the age of 65, and it's all women, and you're going to do that with a DEXA scan. You are testing their bone mineral density. If you have a negative score, what you're looking to do is treat her for her osteoporosis with bisphosphonates. You're going to have the option for vitamin D and calcium. Vitamin D and calcium are prophylactic and should be done after menopause. Vitamin D, 50,000 units per week, should be done if there's vitamin D deficiency. But if you find a positive DEXA scan, that is, she does have osteoporosis, treat with bisphosphonates. That's the right answer. And the one that's gained a lot of ground, men and women, is Hep C. And it's Hep C because we have a treatment for it. Anyone who is a baby boomer gets screened once. Now, it makes sense to me that you would do more than that. People use needle drugs, have HIV, but the USPTF has, as a recommendation, the Hep C antibody is reserved for everyone who's born between the ages of 1945 and 1965. One-time screen. These next few are going to be just general health screening, which is still useful, but these are the ones that come up on the test most often. HIV, everybody gets a screen once. And you do it through an ELISA. If the ELISA is positive, you confirm before you tell them they have HIV. It's everyone once, and then anytime someone wants one. It's called risky behavior or engagement in risky activity. Really, it means that if someone comes in and requests an HIV test, you give it to them. If you think they might have HIV, you give it to them. If they're sexually active, they can get an HIV screen for HIV. And then some of the cardiovascular diseases, which are very popular on testing. Hypertension, diabetes, and dyslipidemia. Hypertension, everyone gets screened every visit. A blood pressure is taken as part of the vital signs, and they're screening for hypertension. However, the diagnosis is made 2 consecutive blood pressures separated by 2 weeks because there might be some element of anxiety, panic, rushing, or white coat hypertension. But the best way to diagnose hypertension is ambulatory blood pressure monitoring. That is, the person goes home, takes their own blood pressure, and writes it down on a piece of paper. That's because the person may have left work, skipped a half day in order to go to the doctor, rushed across town, and is very excited and panicked that they're late and be made to wait in 30 minutes in the waiting room and finally get their blood pressure. Or white coat hypertension, where they come to the clinic, they get anxious, their blood pressure goes up. Doing it at home at the same time on multiple days is a better way to diagnose hypertension. And diabetes is surprising because you'd think the person who gets screened for diabetes would be someone who looks like the type of person who might get it. But the USPTF says people who have hypertension should be screened for diabetes, not obesity. And you do so with an A1C. I want you to hear that the 2-hour glucose tolerance test is a thing, but has largely been replaced by the A1C, except in the setting of gestational diabetes, where the 2-hour glucose tolerance test is a backup to the 1 and 3-hour test. Diabetes, those who have hypertension, get an A1C. Dyslipidemia, now remember, as a risk factor for coronary artery disease, being 45 for a man or 55 for a woman. The numbers are different, but see that 10-degree difference. See why I emphasize 10-degree in a minute. It is said that those who should be screened for dyslipidemia are men greater than or equal to 35, all comers, or those who are greater than 20 with risk factors for coronary artery disease. See the 10 difference? And women who are greater than or equal to 45, 10 difference, 10 difference, or those greater than 20 with risk factors. This is implying that basically everybody who goes to the doctor is going to get screened for cholesterol. And the way you do that is with a lipid panel. And we know now that the main way to treat dyslipidemia is with statins. And you do everything you can to get them on a statin. So other things you can do in clinic to help people, especially the elderly, are going to be things that most people miss. Right? So you do want to screen some people, especially geriatric population, for depression and for mobility. Now don't worry so much about who, because these are less strong recommendations, but things you can do are screen people for depression using the PHQ-9. What is that? Don't worry about it. Just know the PHQ-9. Screen them for depression. Ask them the questions and see if they have any problems. And the other thing to do is mobility. Test their get up and go. Do they have the balance and coordination necessary to pop out of a chair? Or should they be taking it a little bit slower and maybe need some walking assistance like a walker or a cane? Cancer, colon, breast, cervical, lung. Medical disease, AAA, 65 men. Osteoporosis, 65 women. Hep C, baby boomers. HIV, everyone. Hypertension, everyone, every visit. Diabetes, those who have hypertension use the A1C, not the glucose tolerance test. And dyslipidemia are going to be everybody. Treat with statins. Don't forget about your geriatric population, where mood disorder and mobility disorders really creep up on them and cause a major impact on their life. That's screening.